Hello and welcome to Lung Cancer Today, Cancer Nursing Today Roundtable. My name is Dr. Stephen Liu. I'm the Chief of Hematology and Oncology at Georgetown University. I'm here from the World Conference in Lung Cancer, the IASLC meeting on lung cancer here in Barcelona, Spain, joined by three of my colleagues with expertise and experience in thoracic oncology. I'll let my colleagues introduce themselves. Laura?
Hi, I'm Laura Macke. I'm a nurse practitioner at MedStar, Georgetown's Lombardi Comprehensive Cancer Center.
Mary?
Hi, my name is Mary Duffy. I'm a lung cancer nurse at the Peter MacCallum Cancer Center in Melbourne, Australia.
And Shirish?
Shirish Gadgeel, medical oncologist at Henry Ford Cancer in Detroit, Michigan.
So our focus for this is ALK-positive lung cancer, and by that I mean non-small cell lung cancer with a fusion in the ALK gene, anaplastic lymphoma kinase, present in about 5% of non-small cell lung cancers. Now this is a type of cancer that's treated very differently. Most patients, unfortunately today, are diagnosed at a later stage, where the backbone of our treatment is systemic therapy. And unlike other cancers, immunotherapy really not an effective tool in this type of cancer. We rely on targeted agents, but fortunately we have several very effective targeted agents. I think that our preferred drugs today in the US would be tyrosine kinase inhibitors like brigatinib, alectinib, and lorlatinib. Shirish, these three agents, they're all very effective and approved drugs, all I think reasonable options. Can you tell us a little bit about them and maybe how they're the same and how they're different?
One of the remarkable things that has occurred in specifically ALK-positive lung cancer since it was first identified back in 2007 is that over the last 18 years, we have more than 5 drugs now that have been approved in lung cancer, in this particular subset of lung cancer. As you mentioned, the most commonly used drugs are brigatinib, alectinib, and lorlatinib. Just based on the spectrum of activity, we consider brigatinib, alectinib as second-generation ALK inhibitors, whereas lorlatinib is more considered as third generation, though there's no specific biological definition in terms of those generations. Brigatinib and alectinib were evaluated earlier than lorlatinib as both second-line and front-line therapy. And they're primarily used when used currently in the frontline setting in patients with advanced non-small cell lung cancer. And for the most part, the activity of these two drugs is reasonably similar. The median progression-free survival is approximately about 30 months. And the response rate is in the high 70s to low 80s. I think a characteristic feature of all these ALK drugs is the CNS activity. I think either because of certain predilection in ALK-positive lung cancers or because they just live longer, CNS metastases is a common site of occurrence in these patients and a concern. And as is well recognized, the previous treatments, particularly cytotoxic chemotherapy, may not have been as effective in brain metastases, whereas these drugs do provide brain metastases, efficacy against brain metastases. However, what is well known is that patients do progress on these drugs. And so there was a need to develop drugs that could manage patients who had been treated with these second-generation ALK inhibitors. And that's where initially lorlatinib was evaluated, and it did show benefit in these patients, particularly in patients who had progressed in the CNS after having been treated with alectinib and brigatinib. And after it was evaluated as a second-line treatment, it was then moved into the first line. And that was evaluated in the CROWN trial. And though the initial results looked extremely impressive, they did appear to suggest that the benefit was better than what was observed with alectinib and brigatinib in the frontline setting. I genuinely believe that the CROWN presentation by Dr. Ben Solomon at ASCO last year was a landmark presentation in the field of lung cancer, particularly in the field of ALK-positive lung cancer, where for the first time we demonstrated that the median progression-free survival exceeded 5 years, which we had never seen before. So lorlatinib has demonstrated significant benefit as demonstrated by the median PFS. What is quite impressive is the CNS activity. I think particularly in patients who don't have CNS metastases at baseline, hardly any patients develop CNS metastases during the follow-up. So overall, these drugs truly have changed the landscape of ALK-positive lung cancer. And I think a lot of people look at, okay, which drug you would choose. The way I look at it is having more options for our patients just has increased our ability to provide significant benefit to these patients. Broadly, I do lean towards lorlatinib, particularly after the 5-year data, but I don't go into a mindset that this is my first-line drug, and I truly try to assess each patient, look at the different factors, both clinical as well as lifestyle and variety of other factors, and decide what may be the best option for these patients.
I think we've come a long way, and you're right, to first get a diagnosis of metastatic non-small cell lung cancer. We all have this preconceived notion of what that means, but then to find this ALK fusion, to start one of these drugs where your initial treatment may be working for 6, 7, 8, 10 years, I think it's a whole new world. And so to provide that degree of hope, I think is quite remarkable. Now,